Oh, good.
There you go. Don't panic over. Good afternoon, everyone. We are now going to get going. We've got 204 people on the chat and the video session this afternoon. Thank you for joining. We'll now talk through the afternoon session, how it works, and ultimately talk about how the session is going to run this afternoon in terms of agenda. And we've got some exciting news at the very end. In terms of today, it's all about the eConsult Masterclass. It's going to be led by Ross and Gerb, but I'll introduce myself first. My name is Mark Thomas. I'm the Transformation Director for eConsult. We run daily webinars, and today is a special event. It's probably the busiest one that we've ever done, and ultimately, welcome all. So first of all, I'd like to introduce Ross. Ross, can you introduce yourself?
Hi, yeah, so my name's Dr. Ross Dyer-Smith. I'm a GP partner of the Hurley Group in London. I've been doing online consultations since the very early days in 2014 and set up the Hurley Group eHub in early 2017. So I've been running for 3 years now. So done plenty of online consultations and help run a team of clinicians, not just GPs, but pharmacists and nurses that do consultations on a very large scale.
Hi everyone, my name's Gurbaksh Badial. Everyone calls me Gurb. I'm the lead GP for the Hurley Group eHub. Ross and I set the hub up together. As he said, it's been going on for a few years. It's great to be here and meet you all.
Brilliant. Well, thank you very much, guys. Thank you for your time today, and thank you everybody for joining. We have muted you on arrival, and the reason for that is to give you a better experience audio. We are recording it so we can share it with you afterwards. And the way it will work is that we're going to use the chat option. We've got now, if Gerb, you can just move your screen on. We've got two parts to the session: clinical scenarios, where we'll talk through. Ross and Gerb will talk through some particular scenarios and ask for you using the multiple choice questions, a poll to get your thoughts, and then they'll talk that through with you. And then we're going to go into a question and answers, a technical session where you can ask the team how they manage eConsults, top tips and such like, and how to maximise utilisation. It's an hour and a half. We've got some exciting news at the very end, which we're going to share with you. You're the first to know about it. So again, it's to keep you to the very end. And we'll go from there. So without further ado, thank you again for giving me your time. We'll introduce the first scenario. Over to you, Gerb.
Fabulous. Thank you. Right, I think Ross, you were going to start with this one. Is that right?
I was, yeah. So the way we're going to do this is go over, say, some common consultations. What we know is experiential learning really is the thing that really gets you good at online consulting. And I recognise there's a lot of people on this webinar. So as Mark described, that's why we're using the chat function. So what we're going to do is go through a scenario and give you some options about what you might do. And then myself and Gerb will go over how we would approach it. Feel free to post in the chat if there's any particular queries or questions about why you make those kind of decisions. And as I say, there's no wrong or right answer when you're doing an e-consultation. It is down to your own obvious clinical judgment at the end of the day. But we're trying to get you to think a little bit about how you approach those common e-consultations that you might get. So in this particular scenario, it's a 28-year-old female with a past medical history of a UTI about 6 months ago that previously had some treatment, but there's nothing else relevant in the notes. So we'll give you time just to read through this. So we're going to do about 30 seconds per slide, so you've got an opportunity to read through.
On to the next.
So just as a commentary when we're doing this, if you're reading through this online consultation, yes, we've given you 30 seconds per slide, but actually for the experienced online consultants, we would have read just the free text and also just these orange flags that you're seeing. whilst there's lots of other information on there, most of it is negative findings. As experienced online consultants, we tend to only go to those areas if we've got a really specific question in our mind that we just want to check the answer to. But actually, as you can see, this is a common scenario for a UTI, but it's probably asked more questions than you would have done in a face-to-face consultation. But there are some obviously important bits in there that you need to pick out. So the last bit here is mainly around demographics, but we've got to the point now where we need to make a decision about what we're going to do with this young lady.
Okay.
So what's your next course of action?
Oops, sorry.
Do we arrange for some urinalysis? And obviously, I'm just going to caveat that this is a pre-COVID scenario. So let's imagine that COVID hasn't happened. B, prescribe an antibiotic after reviewing the notes. C, ask the patient to come in for an examination and urinalysis. Or D, call the patient and opt for a watch and wait approach.
We're going to open a poll. Should we go for it?
Yep, hopefully it will work. So on the bottom right there, in the polling should have popped up, and you can select your answers. There's a 30-second timer, so you've got 20 seconds left to make your decision about what you might do with this patient.
They're coming in thick and fast. Great stuff. 2, 1. Oh, we have a time limit, and we're done. We just got the 80 seconds for a catch-up Webex is giving us. Thank you, Webex. Okay, let's have a look. I can show the results. Great. Hopefully you can see the results.
There you go. So we've got a large proportion that didn't answer. That's fair enough. It is anonymous. It is anonymous. So don't feel afraid to comment. And even if you're a non-clinician, feel free to have a go. So we've got the vast majority have gone for issue prescription, 44%, and only a few have gone outside. So the reason why we put this one up is for a couple of reasons. Is the first reason is UTI is probably the most impactful clinical condition that you can deal with on an online consultation, and that's because Health Protection England set out the guidance for empirical treatment of UTIs quite a few years ago. And basically, if you've got 3 or more major symptoms, then actually you can treat empirically without having to do any urinalysis or investigation in someone that doesn't have any problems. Now, this particular case, of course, was a young woman who had previously had a UTI, but 6 months ago, and no other significant history. So it's perfectly reasonable to prescribe an antibiotic empirically. Obviously, it's good to check on the notes just to make sure there isn't any allergies or anything like that. The reason why we wouldn't ask the patient to come in for an examination is mainly because it's not really going to add a great deal. If we go back just 2 slides,
sure,
just to the
absolutely.
This one actually. So you'll see here that these are the kind of major questions around sort of the actual UTI itself. One by one, please. And you can see that those major symptoms are there, and actually they're flagged. So actually, with this particular eConsult, once you've read the free text and seen those amber flags, you've pretty much made your decision without having to read the whole thing. So if you go back to the answers again, Gib.
Sure.
Calling the patient and opting for a watch and wait, I think most of us would probably understand that a woman who's complaining of really struggling and, clearly she's saying it's having an issue at work as well. A watch and wait approach probably isn't top of your list. But we'd always say, look, any of those answers are okay. But from a patient experience point of view, think from somebody who's a working young woman, being able to get treatment without actually having to leave her office is a very good experience for them. And what we know from our data, and we've done over 80,000 online consultations, that if you get to these UTI type cases early in the day, we know that you divert patients from then going through multiple routes of healthcare contact. So often these type of patients will do an eConsult, book a telephone call, book a face-to-face appointment, and then actually go up to an urgent care centre because they're so desperate to get sorted out. So this is the reason why we actually in our eHub actually prioritise UTIs as quite high up our list to try and get done. And the other ones are upper respiratory tract infections. I don't know if there's anything else you want to comment on that, Gerd?
Yeah, thank you for that. I mean, exactly. I mean, one of the things I found from doing these is being
the eConsult thing.
Someone's talking.
It's quite difficult. It wouldn't let me log on to begin with.
Mute yourself, please, if you're speaking. Thank you.
Mute yourself. Thank you.
I think what I really like about when I do these kind of eConsults is you can use the message option to provide information about, how they can self-help, and also safety net through that as well. One of the concerns we've had from GPs as well, what if this happens? What if there's a side effect or an issue? But you can safety net quite clearly through an eConsult. And what's really good is it's written, so therefore patients can refer to it later. So you can send links to the NHS website about UTIs, which has a really nice red flag section of when to call 111 if there's a concern. And it's trusted information. So absolutely, in this sort of case, with no history that's concerning, then absolutely prescribing the antibiotic with appropriate advice and safety netting, exactly what Ross says. Cool. Shall we move on to the next?
So just before you move on, Gerb, just to talk about a couple of questions that came through. Sure. Lots of people decided to just, as soon as you started showing that screen, didn't wait for the poll. So I think B was the majority of answers. So well done to those. Unfortunately, there's no prize, but well done. And actually, again, there's a couple of people's sound issues. Unfortunately, that will be yourselves, not us. But we are recording the webinar and we'll share it with you. So just had a question about interoperability. We'll take that through at the very end when we do tricks and tips and talk about systems. But no other questions from that scenario. Thank you.
Oh, yeah. So there was one about sending to pharmacy for management. And absolutely, I think the patient said at the beginning that they'd been trying some over-the-counter treatment and hadn't worked. And also when they fill out an eConsult, before they fill out the form, they have the option of accessing self-help as well. So they can do that. Great. Okay, let's move on to scenario 2. This one. So this is a 19-year-old female university student. Looking on her notes, it says there's a recent consultation for the oral contraceptive pill. She's on microgynon, and there really isn't anything else much in the notes. So let's have a look at the eConsult. So again, about 30 seconds per page. You'll notice that there's a score calculated already, which can be quite helpful for the clinician as we're doing them. On to the next. I'm hoping you can read that. I'll just zoom in a bit and see if that helps. Next one, oops, excuse me. And that's it. So let's go into the questions. So the options are, having read that, I'll just load up the poll in the meantime. All right, so we've got arrange for a consultation, follow-up, video or face-to-face, refer the patient to mental health services and send a message saying you've done so, telephone the patient to discuss their options, or send a message with a link to the local self-help referral IAP service with advice on self-help and safety net. I'll open the poll right now. Webex lets me. There we go. You should see it now. Go for it. Another 30 seconds and we'll discuss the case. So with mental health ones, you'll see that the score is calculated at the top, as I mentioned. You'll also notice you're more likely to get the red flags at the top of the consultation just because it is a mental health consultation. So just it allows you, the idea is it draws your attention to make sure that some of those orange flags are answered and looked at. Also, you'll see there's plenty of space for free text in these as well, so patients can really take the time to discuss their symptoms. We've just got a few seconds left, and I'll share the results. We're all done. All right, I'm going to share the results now, and you should be able to see them. So, majority for this patient picked option C. So 80 people went for that, which is telephone the patient to discuss their options. Then we had a range of video or face-to-face consultation, and then send a message with a link to the local self-help. And nobody picked refer the patient to mental health services. So I think the thinking with this case was trying to get a feel for how concerned the patient is and how concerned you would be as a clinician reading it. What we try and encourage is making sure that we, as safe as possible, can give patients advice, if possible remotely, and if needed, we can speak to them on the phone. I think we had envisaged that a lot of the time, for a person like this, we might be able to send a message with a link. So we might be thinking about option D, to give information about how they might access local mental health services, and safety net with that. I know a lot of people thought that we might phone the patient. Again, that is absolutely fine to do so. You might find that the outcome is the same. And I'd be curious to know what kind of things we'd be looking for if we did a telephone call in this instance. But nevertheless, it is absolutely an option. I'm pleased, obviously, nobody said to refer to mental health services. It doesn't seem it's got to that severity yet. And the other option to do a video consult or a face-to-face would be an acceptable alternative. What we were trying to work out is, are there any queues on the eConsult that allow us to deal with it remotely? And that's why we had envisaged option D from this. There are certain circumstances, certain times, if you look at the eConsult, let me just go back, go to the poll. We know from here that she hasn't got a history of depression, and there's obviously no serious red flag like suicidal thoughts or anything like that. So instantly, my anxiety level reduces a little bit. And I think that's why we're thinking that maybe some advice in the first instance with how to manage it through self-help and IAPT would be a good place to start. Often, when I send these types of eConsult responses, I'll clearly map out how we treat mental health disorders. So I'll put a section on self-help, how to access therapy, and then introduce the idea of something like medication with links to the NHS website to say, this is what they are, have a look, what do you think? So the patients have a very good idea of all the options available, and then they can get back again once they've had an informed discussion or thought about it themselves. So I think that's why we picked option D, outlining all the options with the details of self-help, but obviously come back if there's any concern. Ross, did you want to pick up anything of that?
I mean, I suppose this is an example of very commonly when people first starting e-consulting, these patients were called in or called up, and actually after years of doing this, we found that actually the very, very low risk ones, we knew that kind of interaction in essence didn't didn't actually add a great deal of getting that patient to the actual treatment or help that they needed. Yes, we still do call a lot of these, and we make a judgment often by what's written in the notes. I mean, this is an example of getting a really good history, actually, where it's the patient's really written quite a lot of detail, so it's very rich. You occasionally will obviously get these one-liners that come through where it's not quite as rich, and you just feel, actually, do you know what, I need a bit more. The key thing to it, though, is if you do a telephone call, the commonest mistake that most clinicians make when they do a telephone call is they ring the patient and then say, so tell me what the problem is. And that's not a criticism. We've all been trained to do that from the very first day we started medical school. So that's a natural thing that we would do. But actually, what you should be doing is you read through this concept specifically, and if you've got one or two bits of information that you're missing, those are the two questions that you're going to ask. And you open with, thanks for your eConsult. I'm sorry you're not feeling great. It's great that you've given us all that information. I just wanted to check, has anything changed? The answer to that question inevitably tends to be no, because the response time is pretty quick. And then you then launch straight into those two questions, and you've already got a management plan pretty much formulated based on those two questions. So the telephone call, in essence, is not a 10-minute call that you would normally do. It's going to be a 3-minute call. So it's a good example of where you can utilize that part of an eConsult to help make things a bit more efficient. Even if you do call them, basically.
Yeah, I mean, I will say on the eConsult specifically, she has written she'd like some information, preferably by email, and we are seeing an increasing number of people that actually would prefer an email rather than a telephone consultation, especially with some of the mental health ones and some of the sensitive men's health ones as well. We've had a few people saying, I'd rather have an email response. So that's another thing to watch out for.
Someone's made a really good comment in the chat about if you respond to the cues, which is absolutely spot on. So a lot of people will refer to online consultation as maybe missing cues, but actually the written word has cues written it everywhere. And you will pick up exactly that. And that's a really good point. So when you do respond to the patient in a message, one, obviously showing empathy, and two, responding to those specific cues which are in there, it really helps get a good result, definitely.
Yeah, absolutely. And what I always encourage with our GPs is when they respond to these eConsults, we might reflect some of the same language that patients have used back, so they understand that we've actually understood what they're saying. A couple of comments about how phone call might be better, more personal, better service, and absolutely, this is not applicable to every single case. There is a question about how people are satisfied. And I will say, I look at the data every month from the patient satisfaction survey, and the majority are either very or fairly satisfied with the service they've received. There are some that aren't, various reasons, but on the whole, generally, yes. The answer to that. And like I said, it does also come down to a little bit of your feel within the cues of the patient, what they've written, their history in the notes. Some patients you can tell are kind of just sense checking and thinking, is this something? Whereas some patients are a lot more, I really need help now. And you can kind of gauge it. You can really gauge it from the information you get.
And some of them you will know, of course, which also helps. Some of them will come through and you'll know them very well, and it will change your decision about how you contact them. Because that it's you responding directly to them. You're putting your name at the end of it, and then they're more likely to be okay with that. So
absolutely. And if you start the patient journey face to face or on the video, that could be a good place to start, and then you can follow up by eConsult maybe to begin with. That might be a way to kind of get some experience with it and see how people find it, rather than doing it from the first presentation. That's one way of you might want to do it. Everyone is different.
And we also put things like some comments there in the chat around sort of follow up, and we frequently our ending to a message to a patient is to say even if things aren't quite right, X, Y, and Z. Not just saying here's a solution to your problem. Bye. It's actually setting out what would be the next steps if things don't quite work out, or to do a follow up via eConsult in a couple of weeks. We often use it as a follow up tool as well.
Yeah, agreed. And the comment about how do you know if they say they're not suicidal and the next day they are, it's a fair point. The problem we've got is that could happen face to face. That could happen telephone. It could happen anywhere, really, I would have thought. But it's a difficult one. And I appreciate there is anxiety about that. And we try to manage it as best we can. And there will be instances where you'll get a feel this person needs a call. And that's absolutely fine. There's nowhere we're trying to say that everything should be remote. It's just trying to work out which ones we safely could use. So there is a balancing act clearly involved. Right, should we move on to the next? Okay. All right, Ross.
So this is a 23-year-old male, past medical history of acne, treated with Duet 3 years ago, and nothing else particularly relevant in the notes.
Okay, 30 seconds. I will show a better photo in a sec. Just for clarity, here's a photo. Hopefully you can see that very well. And then the last slide. Oops, that's it. Right then. I'll load the poll.
Okay, so your options with this particular patient is prescribe a tetracycline and send a task to the administrative team to ask the patient to pick it up. Call the patient to discuss the treatment options. Send a patient information leaflet around acne via just a post-consult message, or arrange a face-to-face or video consultation. So Gurbaksh, open the poll.
Open the poll.
30 seconds.
30 seconds. Let's go. Reminds me of doing exams again, huh? While you're doing that, just to say that the photo option now should be available on all templates. Is that right?
It's coming soon. 90% of our templates will have a photo upload option within the next 2 weeks.
Thank you very much. I like the comment about an eConsult exam coming to an eConsultant. Yes, that's what we'll have to. Oh, bit of feedback. Yeah, I like that, eConsultant. All right, 2 seconds and we're done. So I'm just going to show the results. Okay, I hope you can see that.
Everyone just make sure they're still on mute because we're getting some feedback. So if you're not on mute, please mute yourself.
If you can mute yourselves, that would be really helpful.
Okay, so the poll is in, and we've got a third who've declined to answer. 67 people. Come on, people. Have a guess. No one's going to know. Okay, so we've got 70 who have said call the patient. That's so about 35%. And the next highest answer was A at 23%. And C 15 sending a messaging link. So when we talk through this particular case, whilst it was a relatively sort of straightforward one, in the sense that this is somebody with acne that hasn't really got a great response from topical treatment. So your next kind of sort of management option is probably going to be an oral antibiotic type treatment. Yeah. And the issue with it So the first sort of reaction is, well, actually, okay, well, I can do a prescription, therefore I can do that remotely. Great. The only issue with tetracycline, of course, is it's a slightly tricky medication for some people. And so probably in most cases, we would be giving them a call because of the nature of the medication. And it's obviously specifically relevant in women of childbearing age as well. So that's probably what we would go for. And, you know, again, the other options are okay. You know, prescribing tetracycline and sending a task to admin, you know, could be possible if they'd had it before, for instance, or, you know, knew about it already or had a previous discussion. You know, that's a potential. I think probably what I would have added to A, though, is that there would have been some communication, I think, from us saying, look, this is the medication. This is something about that you need to read about it to know about it.
Absolutely. I think that's what someone, sorry, Ross, I didn't interrupt. That's what I think someone was just also mentioning about that. So we had envisaged, obviously, option B as being the kind of go-to, mainly for the fact of medication and side effects. I think absolutely there's been a discussion about, you know, you can write, you're given a script, send a link and fed back up the side effects. Absolutely. And increasingly, we are doing a lot of that by message. It comes down to experience as well and what you feel comfortable with. For example, if you've got a lot of experience in this field particularly, then you might feel more confident to do it. And again, there's no right or wrong. It's just that, you know, the case is really to show, A, the use of a photo and how you don't necessarily need to bring them in, which I'm pleased no one wanted to do on that basis, which is good. But secondly, you know, your remote options, what you could do. And I really think either is okay, to be honest. The other thing I was going to say, somebody's mentioned about when you refer to outcome, what you're referring to, we mean what operational outcome what you've decided to do. Ask them to come in face-to-face for an appointment, a prescription, a telephone call, maybe a combination. And then someone's asked, general advice. Yes, so the idea is that, like Mark said, most of them now, templates should have the photo option attached to it, and the rest of it's coming. Is that right? Did you say?
Yeah, so I just talked all that. So the moment is eyes, face, and skin. That's the template. So got a photo upload option. We are going to 90%, including general advice and even things like medication reviews. And the photographs, they'll be able to upload 4 photographs for each template, which is great. Again, it gives you that power. You're in control then, and you can make the decisions. So again, as Ross and Gurbaksh said, these are the options that they put up for your thoughts. But yeah, ultimately it's down to you how you want to manage the patient. But certainly B was the answer that most of the people on the webinar today selected.
Yeah, agreed. And I will say, just on a side note, having the photos, I mean, they are so helpful. And at first, we were worried about whether people would want to do them, but we've received so many photos of people who really don't mind taking photos of all sorts of things. They just send it through. So actually, they are hugely helpful. And the question about storing them securely, because they're part of the eConsult report, the report gets saved into the notes, and the photos are part of that report. So yes.
There's been some stuff around kind of sort of consent. It's taken at the point that they consult. So, I mean, one of the things we do whenever we train clinicians is actually say, go and do an eConsult yourself. So you're actually assuring yourself about actually what they have to go through. It's a really great way. It's a really great way to get to learn sort of empathy and experience what a patient has to go through. But for instance, the photo uploads which are on the child templates will say if it's in an intimate area, it won't give them a photo option. So if they happen to say that it's the groin or the genitals, actually that photo option won't surface in the eConsult. So actually, as we know, obviously there's quite a tricky area from the point of view of the law. There is something going to be coming out from NHS England, I think, soon about that as well, because obviously it's caused quite an issue during COVID. But it's just to assure you guys that actually it's a safe process and the consent's taken from the patient at that point.
Absolutely.
Brilliant. Before you move on to the next scenario, a couple of questions about our one-way message platform and the information not being saved automatically in the records. To wait to the end, we've got some exciting news, and that's all part of our roadmap for the next few months.
Absolutely. And quick question about patient satisfaction as an outcome. Yes, the difficulty we've got is the data is anonymized for the survey results patients get a week later from when they send the eConsult. So it's very difficult for us to attach that to a particular outcome that we've done. If you see what I mean, we get them collated. But we do look at them, and we have all the free text comments from patients, and there have been some really useful points on there that has allowed us to change and update our system. And over time, it's been getting better. I think that was it.
Yeah, and we would say we use the free text. Actually, we use word clouds. So often we'll get literally cut and paste the whole feedback section of the free text and put it into a word cloud, so that it very quickly tells us the themes of patients, whether that be positive or negative. It's really
absolutely.
It's really helpful.
Oh, you're slightly, Ross, but I think we got what you said about using the word cloud. Yeah, absolutely. And like I said, if you do the word cloud from the last quarter, the main things that come up are time, appointment, and quick. So those sorts of things that patients are saying when they're giving their feedback. So.
And again, the power of the session today, it's really good to see you actually, the people on the webinar actually coming up with solutions and answers themselves. So that's really good. Thank you for taking part and being really interactive in the session.
Fabulous. Should we move on? All right, so this patient is a 27-year-old female. In the notes, you can see that she last had a consultation 6 months ago for a pill check. Nothing else much. So let me get my trusted timer. Start. Apologies if the name changes throughout the eConsult. I might have modified it slightly using Paint. Okay. And that's it. So here are your options from that. Option A, prescribe the OCP via EPS and send a message to the patient to inform them. B, ask them to make an appointment for a pill check. Or C, call the patient for more information. Just going to upload the poll. Bear with me. Okay, don't say no. Bear with me, sorry everyone. And I'm opening it now. So please answer. You've got about 30 seconds. They're coming in thick and fast.
It's like a horse race, Gerb. I'm waiting for the winner to
come on. Yeah, we don't have individual names of people doing them, but no,
but I can see which one's going to be the winner.
It's like ask, you know, like in Who Wants to Be a Millionaire, when they've got Ask the Audience.
D.
I missed that.
D, Jeremy. D,
Jeremy. Yeah. Okay, just a few seconds more for it to finish. Okay. Great. I'm just going to apply the results and let's go through them. Hopefully you can see that. So 156 responded. The vast majority said they would prescribe the pill, send a message to inform them. A few said ask the patient to make an appointment, and some said call the patient too. So absolutely, as you kind of have all said, what we envisaged from this was to send the patient a prescription and inform them about it. A couple of reasons. So obviously, as you can tell, they had a recent check. What's great about the contraceptive review template is it will ask all the kind of UK MEC type of questions that we know that we need to hear. Plus, they can enter their blood pressure and weight to make it absolutely updated. Although you could argue, even if they had that from 6 months ago, that might still be okay, but they provided it for you anyway. So on that basis, given the fact that they've been unstable for a little while, and you've got the information, we thought this is more straightforward. Now, clearly, it depends how your practices work. That you may have, I've seen some messages come up about pharmacists that get them, and you may find out or find a way where you can filter some e-consults that are relevant to your pharmacist in-house or your practice nurse, so they can deal with them in their appointment slots. That's also absolutely fine. Very much depends on how you want to set it up. Excuse me. We didn't particularly think here that we'd want to ask them for an appointment pill check because it's kind of already been done. And calling the patient, we didn't really think there'd be any value in getting more information. So it's more straightforward. So I'm glad we're kind of all in agreement with that. Ross, is there anything you want to add?
Not really. Just to say that in the days that we used to do face-to-face, which seems like a long time ago now, I frequently would have young women coming in to have face-to-face appointments for pill check because they're used to doing it that way. And I would always take the opportunity at that point to show them. And it's still one of my bookmarks on my desktop to show the actual you can basically get the pill review URL from your eConsult website, from your practice website. And I keep it saved as a page so that I can show them it. And then I'll say, look, I'll send this out to you in 11 months, if I give them a year's pill, so that actually goes out to them a month before their pills are due, and put it as part of your recall schedules. And in essence, for your very, very stable patients, as long as they have an understanding that obviously you need a blood pressure and up-to-date weight, then actually that's a really good way of making or freeing up some capacity within the practice. I mean, it's not for everybody, but actually for a very large proportion of young women, when I can't think of the last person that said to me that's not a good idea. Every single one of them seems to say, why didn't I know about this? Because most of them have had to take time off work to come in, kind of know the same, they're going to just sit down and I'm going to take their blood pressure and I'm going to give them what they need.
Absolutely.
And yes, I understand that there are other opportunities at that point in some cases, maybe talking about sexual health or other things that might be in the notes. But again, you've got that opportunity when you review the eConsult. If you think there's something else might need to be picked up, then you've got that opportunity, of course, if you wish.
Absolutely. And I think Natasha's written about discussing LARCs, and it's a good point. I think realistically, this particular eConsult was more of a follow-up from a review 6 months ago. But if you're doing the annual review, which you can do via eConsult, the specific template called contraceptive review, which is in your I need a review section on the website, in responding to that, that's when I'd be thinking about making sure my response, we include this is the information about LARCs in case you're interested, and and a signpost to the NHS website, which is really detailed about LARCs. I had a look at it recently; it's excellent. So you may not get the response immediately when you send it that way, but you can at least give the information. And if the patient decides they do want to consider a LARC or anything like that, they can always get back to you at another point. So it doesn't always ask. You don't always have to ask about that. I would argue every consultation, maybe the yearly review. Does the template ask would they like more information about LARC? At top of my head, I don't know. I'd have to double check. Sorry. I'm afraid I don't know.
But we'll take that back. That's a good question. Certainly, the annual reviews. We're going to have another session in 2 weeks for clinicians, nurses, to talk about reviews, annual reviews, how to use our long-term condition templates. But we're adding new content all the time to our templates based on your feedback. So keep letting us know, and we'll review that for you.
Fab. Shall we move on? Last question. We're running through these. Okay. Here we go. Ross.
So this is a 48-year-old male, past medical history 6 months ago, seen for a minor work-related injury, and they're a builder.
Mm-hmm. Move on to the next. The next page, it's a bit clearer.
This is a slightly older version of eConsults, so these are some of our dummy ones from quite a few years ago that we've used for trading. So actually the format's slightly different now, where you actually get the pictures at the end in a larger format.
Yeah, absolutely. And you'll get a blue flag at the beginning of the report to say there are pictures further down. Sorry, it might be a bit blurry, but I'm hoping it's visible. And then, is there anything else? Just a few little bits about. Okay, I will get the options up and load the poll.
So your options on this one are, again, face-to-face video, call the patient to gather more information, call the patient, refer by 2-week wait, or make an appointment for cryotherapy. Again, I appreciate this is MCQ and there are plenty of other options you could do. But to make this interactive, we had to sort of limit the options, but there are more, of course.
We doctors love quizzes, I'm sure. I know that for a fact. Right, I'm opening the poll now. There we go. Off you go. They're coming in. Let's see if we can get a high proportion.
There's quite a few people, I think, watching in large groups, so they're not near the screen.
Oh, fair enough.
So we'll let them off.
Oh, absolutely. Or if you're not a clinician, fair enough. You can always guess.
Or they're shy.
A few more seconds. Great. I'm just going to share the responses. There we go. Hopefully you can see that.
So the overwhelming majority went for referring on a 2-week wait. So that was 124 out of our 194. So
194.
One person went for call the patient to get a bit more information, and 8%, 16 went for arrange face-to-face video consultation. So this one we created specifically to not catch people out, but if you see the actual template that's come in right at the beginning, at the top of it, it's what the patient selected. So they've obviously thought it was something minor and picked that up. But as you start to sort of read, your concern, I imagine, grows, as I can tell by your answers. And then obviously by the time you've actually got to the photograph, that's a malignant melanoma. Now, you know, some people will say, well, why don't you just refer that straight off and send a message? That's a fair point. But, you know, we would always say, if you're referring someone for a cancer referral, they need to know. And sending it via a message probably isn't the best way of doing so, because they're likely to have lots of questions. So, you know, we put this in there as a kind of learning for our clinicians around, you know, seeing the power of what images, especially still images. So one of the issues with video, for instance, is if you do call up and do a video call, it doesn't work particularly well with motion. So if you're viewing a skin rash over video, it inevitably is terrible resolution, even if you're both using extremely high def and have very, very good internet connections. And that's just mainly down to motion. So it's the static nature of a static photograph that gives you more detail. Now, in some cases you're going to be unclear and you might have to see some lesions, of course. But we're finding that patients are getting better at taking photographs, because obviously some of it is down to operator ability. So one of the key things about reviewing photographs is, much like you were probably all taught to look at an X-ray, is to have a look at the quality of it. Because actually that's something that I write now. If I'm making a management decision, I'll write what I believe the quality of that photograph is. Because if it's poor, then I might make a different decision. But as you've all spotted, and I can tell from your responses that that's a melanoma and needs seeing and sorting. And I'd often make the point that, and I did on a recent webinar I did a few weeks ago around. There was a lady that I saw who he did an eConsult about a breast lump, but I didn't see them. I referred them straight for a 2-week wait. Now I know that lady probably would have waited maybe 2, possibly 3 weeks for a routine appointment. Instead, she submitted at 8 a.m. and I'd referred her on a 2-week wait by 11, and she was seen the following day in a cancer clinic and diagnosed with breast cancer. So from a patient journey perspective, you've got the ability to turn these things around a lot quicker. But yeah, that I don't know if you've got any comments about that, Gurb, yourself.
Yeah, absolutely. I'm just having a look at the questions coming in the chat. So, one question about how is it easier compared to telephone appointment? Well, I mean, the key difference is you can see it, whereas telephone you might not. You could argue you could do a video call and you could get to the same conclusion. But, having seen, I'm sure, multiple lesions over the years, I'm sure you'll be able to recognize this as quite abnormal quite quickly. So the idea would be, with a good quality photo, you can make a decision fairly quickly rather than having to spend time speaking to the patient or video calling them. And as we all know, every minute counts when you've got sessions going on. So clearly, I think that's why we were thinking, to be honest. I love the fact that somebody said that because he's a builder, they underestimate quotes and skin problems. Well, there we go. Read a lesion template. Yeah, so if people, for example, put in a description of a lesion in a general advice template, the idea will be that now they'll be able to add a photo, as Mark has already mentioned, so that will be good. A question about this is risky because it wasn't flagged, and that really was the point. The patient may not know the diagnosis, so they pick a condition they think it is, but they don't know for sure, and that's why it's up to us as clinicians and practices to make sure that all reports are reviewed. So making sure we have a robust system where whatever eConsult comes through, that somebody is looking at them. Specifically, obviously, for clinical queries. Anything else? We've got a few things that we'll talk about complex patients in a sec. I think that's more of a generic question. And certainly, I've had a few instances where I referred on a 2-week wait basis on an eConsult. Like Ross said, it has definitely saved time. What I'm asking patients to resubmit with higher resolution pictures? Yes, I have done that before. I sometimes give them the option. I say, look, I know you've done an eConsult already. The quality could be better. If you're happy to, would you mind doing another eConsult for us? Because I don't want to force people to do it if they've tried and they're not able to. But asking them to give them the option. Otherwise, they can always call up for an appointment.
As there's a comment there about, is there not a quicker way of doing it? I think the point that I would make is, if I'm calling this patient up, I'm ringing them up and saying, thanks for your eConsult. That skin lesion actually, or that thing on your skin probably isn't just a wart. It's actually something quite serious. I think we need to send to a clinic. I'm not collecting the history. That's why it's quicker. I'm not having to spend 10 minutes to take the history. And actually, even if I do, even if it does take longer, the time that I'm going to spend is going to be talking about the patient's worry about going to the clinic, what it means, what's the potential diagnosis, all the really, really important stuff they will ask you at that point. So this is the reason why I prefer this method, because you've got that history. It's also documented for you as well. So the patient's done the documentation for you and written the history. So I'll often send these with referrals. So I'll send the eConsult with a referral. So it's got the photo on it as well and the history.
Yeah, absolutely. Okay, somebody's saying obviously it's not AI, so it does not replace clinical acumen. Absolutely, good answer, and that's it. So it's kind of allowing you to triage in your mind as a clinician what you're going to do with it. Okay, so a few generic questions.
Yes,
about...
I think it's you've gone through the scenarios now, which is brilliant. Now we're going to open up to general questions. There's a few on the chat which we'll now start to talk through. And there's a couple of questions there about the urgency and what the eConsult platform's for. So do you want to guys talk about the urgent, what happens to somebody that can't do an eConsult? What's the process in your environment?
It depends what model you're doing, as in the sense of if someone gets booted out of the consult, as it were. Yeah. So there are essentially two kind of rejections, really. One is, look, this is definitely not the route of entry that you should be coming through, in the sense of, someone puts in that they've got central crushing chest pain going down their arm. That's basically saying this is not an appropriate servicing, really. You've got to be going to A&E for that. The second one is a slightly softer rejection, which basically saying is your condition actually is probably more serious. It's not a trip to A&E, but it's actually something that requires a little bit more urgency. And so we have a system set up in place where, and essentially our patients who are red flagged, that's a slightly different system at the practices that we work at, that puts them onto a callback list, and it's very few and far between. But it means that actually those ones that are slightly urgent, more urgent, can actually come through that way. Yes, probably some of you thinking, well, can patients game that? Well, yeah, of course they can. But I've not worked in a system where patients haven't worked how to game something at some point. But actually, it's quite a small proportion. And what we know is that because of the way that eConsult works and actually flags out some of those patients that are urgent, is actually we're seeing lower acuity. So I think a lot of people forget that actually the triage has been done. So quite a lot of re-triaging I find happens when I speak to GPs who are starting with eConsult. They're sort of, oh, we need to triage them. And actually, well, the important triage has been done for you, in the sense that you see low acuity stuff as a general rule in eConsult.
Yeah, sorry. No, go on.
We're now ready for that general questions and answer section. We will go through the questions. We'll try and clump them together in obviously categories. So we'll do that now. If you haven't asked a question, now's your chance, and we will try and capture that. We're recording this session, and we will capture the chat information as well, and try and give you that information back in some content as well. So the first question for you guys, Gerb or Ross, do patients prefer to have bad news face-to-face than over the phone?
Well, a really good question. In my experience, I would say face-to-face. So we have a policy for if a patient asks for an eConsult, for example, they want some results. And let's say, for example, we've got a new diagnosis of diabetes. We wouldn't be doing that by over eConsult. So we would explain to the patient, got the results, we'd like to see you in person to discuss them, and then we'd book a face-to-face or video appointment currently to explain that to them. So very much so. So we are very clear that anything significant like that, and obviously it does depend a little bit on the judgment of the clinician, that we wouldn't be doing that via email or really even by telephone. If we can see them face-to-face, all the better, current circumstances notwithstanding. So that's what I would say to that, really. Yeah.
It depends. I mean, obviously, right now as well, of course, is that we're in a situation where we're having to do a lot of this, which is an unfortunate circumstance to be in. We've had to break some pretty awful news over the phone. So we're all, I suppose, many of us are learning to do it. It's not to say it would be my preferred method, of course not, but it is something we're having to do at the moment.
So there's a few questions about, obviously, our platform. Just to let you know, when patient starts their journey, as somebody said, it's the patient inputting information. We've got several safety features built in to divert patients that we don't think can be managed at the longest by the end of the next working day. And that's things like COVID questions, the emergency questions, chest pain, breathing difficulties, etc. And then we're looking at free text and the way that patients answer questions, yes or no, and ultimately also pain scoring as well. So lots of safety mechanisms. And at the very end, when a patient submits an eConsult, they get upfront information about what to do if the matter gets worse. So that's all part of our process. In terms of, a few people have commented about how do you record one-way messages using our platform in the clinical notes. How are you guys doing that? And We're going to talk about that very shortly, but how do you manage that at the moment?
I do it basically depending on, I do it the opposite way around now. So what I used to do was use post consult message. You obviously have the option to copy to clipboard and then paste in, but actually what I tend to do is write my response within the clinical system, and do it the opposite way around. And it's just a preferred way. But also I've started to use synonyms, because quite a lot of my responses are, or certainly my start to my responses and my finishes tend to be the same. So for those that don't know, a synonym basically is where you put in, and this is specific to EMIS, I'm not sure whether it's in System 1, but you can specify 3 letters, and then specify what those 3 letters will mean in terms of text. And when you press return, that's what it will produce. So I'll frequently do it in, so when I'm doing examinations, for instance, when I get a clear chest, I've got CCL, I put that in and it'll put chest clear entry equal bilateral, blah, blah, blah. So you can do the same with kind of post-consult messaging. So you can put some of your more common responses in there, you can still edit them. And then I copy and paste it into post-consult message from there at the moment. That's how I do it.
Yeah, absolutely. And I'll be honest, I do it the other way. I mean, I like to write my message and then copy it in. To be honest, that's what, yeah, it's just the same sort of thing, really.
There's quite a few questions, which I think is interesting. Again, we're running daily webinars, obviously not just for clinicians the rest of the week, and obviously next 2 weeks, and we have been done since lockdown. So about 1,500 practices and more have joined us, which is brilliant. However, it is about managing workload, managing eConsults as they come in. And it's, again, how do you guys work in terms of eConsults coming in, a cut off each day? How do you manage the end of the day message and not automatically dealing with a patient that perhaps can be managed further down the road, if you like?
Yeah, absolutely. Well, I think that it depends on the model you run. The main thing about eConsult is that the expectation is that the patient gets a response by the end of the next working day. But that doesn't necessarily mean that you've kind of solved the whole issue then. So you might just send them a message to say, actually, I agree with you when you talk about this. You've screened it's not urgent, so you book them a telephone call a few days down the line or next week. So you can manage it that way. I think that there is often pressure thinking that you have to deal with everything immediately. Depending on what the situation is, you may be able to kind of, delegate. So that's one thing. The second thing is obviously making sure that you have eConsults integrated into your appointment book and not looked at as additional, so that it's kind of part of your normal workload. In terms of times, very good point. Patients can fill out an eConsult 24 hours a day, anytime. And through the safety mechanisms that Mark has mentioned, they are kind of signposted off if there is anything serious. So there isn't really a cut-off time per se. Now, what you might want to do is you might have a system where you could say to the patients, well, anything, if you submit an eConsult between these hours in the day, we'll do those on the day. So you, for example, replacing your kind of telephone triage, you might say, right, eConsults between 8 and 1, that's our normal triage slots. You do an eConsult, we'll get back to you on the same day, and anything else could be routine and can be looked at that day or the day after. So, it does depend on your model, and there isn't really one set way of doing it. It depends very much on how much staffing you have, the confidence in using it, and what the patients are like. So there are factors there. I don't know, Ross, if you want to pick up on that.
Yeah, I mean, sometimes we overperform. So we have a cutoff around about 2, but actually we find that sometimes we're getting back to people within half an hour of them submitting an eConsult, which is always a great day. But one of the things that we know is that the predictability of eConsults and how they come in very much reflects sort of traditional general practice, which is quite interesting given that they can actually do this at any time. But every practice pretty much has the same sort of throughput profile. So we looked at I think the data of around 2 million eConsults, or 1 million, I can't remember. It was a lot, but basically you get a peak at 9 a.m. on a Monday morning. That's your highest peak of the week, and you get exactly the same sort of slightly skewed curve, peaking at sort of 9 a.m. and then drifting off, and another little bump normally sort of slightly later on in the day around about 4. And that curve is reflected in every single day of the week, apart from on Tuesday, the volume is less, Wednesday less, Thursday less, and then you get a little bit of a bump on Friday, pretty low input on a Saturday, and a slight bump on a Sunday afternoon. And it reflects, I'm sure, the traditional kind of opening hours of general practice in times gone by. So you can kind of predict that. And one of the things that we've got really good at is actually we know roughly how much of a bounce, I refer to it as a bounce, that we're going to get after a bank holiday weekend. So we look back at our previous year's data. So the last bank holiday weekend that went, we looked back the preceding year and said, well, how much more did we get on a Tuesday on that May Day bank holiday? I think it was around 23% more.
Yeah.
And then we put in slightly more capacity, roughly 20% for that day, and we had slightly more, maybe about 26%, but it wasn't unmanageable. And so we often plan in that way. And actually, your preceding week's data, once you get going and are relatively established, is normally the most important one on actually predicting what's going to come in the following week. And there are slightly more nuanced days around Christmas, that kind of stuff, but in the most part, it's relatively predictable.
Absolutely. I mean, the question about the demand data, I 100% agree. And I think one of the concerns about eConsult has been, well, people worry about kind of, the gates being flooded because patients can access whenever. But from our experience, we found that giving them the option doing it whenever, we still have relatively, like Ross said, predictable peaks, which is really surprising because you'd think that maybe it'd just be going up exponentially, but it just doesn't happen. And unfortunately, there's no, as I'm sure you're all aware, no real good way of collecting demand data because we are limited by the number of appointments we have in our surgeries. So we don't know what the true latent demand is. So inevitably, I think when you first start using them, there may well be a peak. People do get used to them. And if you can integrate it into your workbook with appropriate comms to the patients, and ideally actually involving them when you start using the system, about how they want to use it, then I firmly believe that it is manageable. I think, like Ross said, changing your capacity on certain days, like a Monday, is a good place to start to make sure you've got enough people on the ground. Okay, let's have a look.
Mark, you're still on mute if you're asking.
Yeah, I'm muted now, just school error. I'm mute to be quiet and then I have to talk. One of the questions, again, really good question from lots of people asking about, it's only done in one language. Obviously, you guys are working in central London. How do you find that?
Ross, me?
Shall
I take it? Okay, no problem. Yeah, absolutely. Good question. Well, what we find, the vast majority that I've seen that we do, and we do a couple of thousand a week, they are fine. And the English is used. I think a lot of it, because they're multiple choice questions, there is free text as well. It makes it a little bit easier for patients if English isn't their first language. What we have done is we have encouraged, if people can't do it themselves, they can get help to do it from someone else. So we've even had circumstances where a receptionist can help a patient fill out an eConsult if they've got difficulty. That's one way you can do it. And the final thing I'd say is that for people that are really difficult, so for example, not really difficult, but it's difficult for them, like to fill it out, or maybe they don't have a smartphone. The whole point is, if we filter out those that can, then there should be hopefully some time for those that can't. So there will always be people who can't use eConsult for whatever reason. So the thinking is that there'll be some capacity built in that you can bring them in, speak to them on the phone, or whatever you need to do. So that's what I would kind of say to that.
Again, there's a few questions there around about obviously managing demand and obviously volume. Talk to myself. I've put my email address in the chat option. If you want our support from transformation to ops, and obviously we can link in Gerb and Ross as well. Sure. We can help you manage demand. We can help that. The biggest interest at the moment is around total triage. We've probably got 6 or 7 practices a week moving to that, using eConsult as their preferred route. So again, talk to us. Another question is about EPS and how can you use that as part of the eConsult one-way message, if you like. How can you tell patients?
Is this around, I saw that one, yeah. So this is around nominations. So
yes.
The interesting thing is obviously EPS4, if you're not aware, actually does away with nominations. So patients now don't actually have to have a nominated pharmacy, because actually the way that EPS works is it sends the prescription up to the spine, and then that a receiving nominated pharmacy can then retrieve it from the spine to actually dispense it. EPS4, which has been launched now, means that actually a nomination is not actually required, and a patient can actually walk in with either the actual prescription code, which is off the barcode, a paper token, which of course not many people are using at the moment, or present with their NHS number as well. They can do that. So it has been, it's not, well, it is coming, and obviously they're trying to roll it out outside, but what we'll often do is make a decision if someone hasn't got a nomination. So for the prior to EPS4 arriving, what we used to do was I'd send a message to patients saying, look, I think you've got a UTI, I think you need a prescription. I've sent it to this pharmacy. If it's not the correct one, or the one closest to you, or what have you, then get in touch. And then we just had a process at the desk if people called up for that, and we would just resend them. But that's normally just done through a task, and that tends to work most of the time. A lot of other prescriptions, of course, are done when you're on the phone, and so you're asking. But it's just making sure that patients have a choice, and that's what we tried to sort of build in, was just making sure that if they didn't have a nomination and we picked one for them, that actually we made sure they had a choice and they could actually choose. But as many of you, as you're in practices, will have, your populations tend to come to pharmacies that are relatively close by. So, but we will get the occasional one who's obviously done an eConsult when they've gone to visit a relative, for instance. Most of the time they'll actually state that's where they are. So we'll often contact those directly just to work out what their postcode is, so we can deliver one to nearby.
Yeah, that's been a really good one, actually. A good example. I've had people that are on holiday locally, so it might be in the part of the country, and they've had a flare. I had one that was a flare-up of eczema, really good photos, and I could send a script for some steroids to their local pharmacy. I think it was in Newcastle or something, so a little bit further away from where they normally live, and it was resolved. So that was a good option. I think someone said not everybody EPS4 has been delayed for us locally, and my understanding is EPS is everywhere apart from Wales. So EPS2 should still be available, which is what Ross talked about, setting a nomination. And then for those that don't, some people say, I don't want it electronically, there is always the option of saying, okay, well, the script's printed out for you. Obviously, with COVID, it makes things a bit more difficult, so things may have changed. But generally speaking, that's what we can say. If they really don't want it to be collected electronically, you can ask to be printed out at site.
So I got a question about are you finding like the tech savvy jump to queue by doing an eConsult? That's a good question. And again, I'm watching the audience, if you like, responding to that already, which is brilliant. It's about improving access for everyone. The more people do eConsult, the better it does. How do you find that? Do you see a different way of interacting with practice? Patients,
sorry. Certainly, I think that people will get used to it very quickly, some people, and they will become, someone mentioned about people using it quite a lot, which is another thing I wanted to talk about. And they will engage with the system very well. So they'll kind of understand what an eConsult is, what you said back, and they might do it X number of times. So yes, so more tech savvy then may be more likely to do it. Again, it comes down to the point that if they're doing it that way, we're hoping that there'll be more time for those that can't traditionally. So they might still want to phone up and make an appointment. But then ideally be a little bit easier to get that face-to-face or telephone appointment directly, because the other patients are doing eConsults. I mean, that's kind of what I normally think when I think to that. I mean, you're right. The problem is, well, if you do an eConsult, your problem dealt with sooner. And again, it comes down to how you triage it. So as in internal triage, well, actually, this is a routine problem. So I'm going to sort out a routine appointment for this person. So you don't have to deal with the issue there and then. So then you can be a bit more equal. It's the same thing, for example, when patients do eConsults requesting routine repeats. Our normal practice turnaround is 48 hours or 2 working days. So if they were doing eConsult saying, I want my repeat prescription, should they be getting their prescription quicker? And we say no. So the idea is we say it will be it will be done within 2 working days, and we add it to the practice workflow as normal. So it is possible. It's just all about how you filter it out in your practice and how you triage it, I would say.
There is that one around kind of people, I talk about digital sort of exclusion and inclusion, but and people will often level that at some of of many kind of digital health solutions, but that's been going on since the year dot. I mean, when telephones came in, you know, I know two of my colleagues who or friends who work in the city who've got super fast sort of connected phones, and they say the way they get through to their GP practice is to have 3 phones on, and they press dial on all 3 of them. So, you know, that kind of stuff has been going on for a very long time, no matter what you use. The key is making sure that you don't shut off other routes completely. And that's the key here, is that you're channel shifting. So people who refer to, oh, it's additional work, I say, well, no, it's work you still were dealing with, but what you've got to do is take away some of the resource that you're using for face-to-face and point that at our consultation route, and also carve out some space for your long-term condition patients. So, you know, we split it into kind of on the day and planned care, so that we're trying to get more time for our doctors to spend time with those patients that need more time to deal with more complex issues that might need face-to-face, whilst dealing with the simpler, slightly lower risk stuff, as it were, within eConsult, because it's easier to see what's coming in. So, you know, the key with that is, with an e-consultation, you've got more detail about what the problem is, as opposed to when you were doing telephone triage, for instance, where you had maybe one line that said chest pain, you had a list of 50 patients, you were trying to decide which one you were going to call first. Do you just start at the top of the list because they got there first, or do you look down and try and work out which one's the serious one? So, you know, you've got the ability to be able to make those decisions. So it is about planning out your workflow. And I'm a massive fan of process mapping. I know some people find it really frustrating, but literally getting your team and sticking a load of post-it notes up on the wall and trying to work out the best way to flow these particular types of patients is a really rewarding experience for everybody, and normally gets you to the solution you need.
To make it better. This is not about additional work. This is about changing the way you work. The worst phrase in the English language, we've always done it this way. You've changed more in 8 or 9 weeks than you have done in probably 8 or 9 years. We want to help that and make this a digital journey that's better for your patients, better for you. That's why everybody's now interested in total triage, because telephone triage versus eConsult, a couple of words on the screen versus 2 or 3 pages, and some photographs of the quality that you've already seen. Lots of questions about interop, about delivering eConsults direct to the clinical system. Just to let you know, we've got about 10 minutes left now, so we're just going to go into final catch-up on questions. We'll talk about interop and some of the exciting features we've got coming. And Ross, are you able to show us your toolbar? Is that possible?
Yeah, I can. If Gerb hands over to me, I can do that.
We did promise some exciting news for you, and a development that we're just letting you know now. It's going to be rolled out to a test group next week, with a view to potentially rolling out to every practice, regardless of your clinical system, in the next 2 weeks.
Okay, so can you see my screen, Mark? Just confirm.
Yes, we can.
Yeah,
okay.
we can see it.
So this is the new toolbar up here. So the widget that sits up there. The first thing to show you is the new post-consult messaging system. So some of you may have noticed when you get your eConsults, there's a URL there and a PIN number. So now you can just use this to respond. I haven't got a live pin that I can utilize at the moment, but you basically,
I can give you
yeah, if you give me a pin, Gerb, I'll put
sure. Yeah.
So you can put a pin in here, and then it essentially will give you it shows you where that pin is there. So it's roughly at the top of the eConsult.
Yeah. It's Charlie Victor 6, Sierra Percy 8.
So this is your post-consult message screen. So you'll see that this has been updated now as well, in the sense that actually it has some free text already in there. You could obviously edit and take away whatever you like. You can also send a file, so we use this for Med3s now. And there's a couple more options, but you know, it used to be that this was at the bottom, but obviously most of us, when we're writing responses and want to make them personalized, tend to use these mainly. The only time when we tend to use the very quick ones are often when we're doing something that's very transactional, like it might be, you know, just sorting out a prescription quickly, or a repeat sick note, for instance. So that's the first part. There is a video consultation option here now, which is through Q Health. So you can essentially sort out a video consultation there and then, so you can either do one that is booked or create one immediately. And you can also send it via email and SMS if you wish, or you can copy it to the clipboard and send it as a URL link if you wish as well. And once you've sent it, basically you have it pops up here, and then you can just hit join and it opens it up instantly to be able to speak to the patient via a video call. So that's been a great addition. There is most of the news that comes through around updates from eConsult will be here. And this takes you through to the eConsult website as well. So this is the kind of early version of it, which will be going out for the early practice adopters, and then we'll be essentially developing it from there onwards. So the key thing for us really is certainly around the messaging, especially for some of those practices like EMIS practices that essentially have a rendered PDF in the system that isn't as helpful as it could be, as it were.
Brilliant. Well, thank you very much. That's coming soon, everybody. As part of that process and the future upgrades, we'll have things like self-care content you can copy and paste straight into the one-way messaging. And one of the questions that's come up a few times, the difference between Accurex and ourselves, and we have no problem with Accurex, we use Accurex ourselves. However, we're going to be able to read and write into the clinical records on all clinical systems, and that's on our roadmap in the coming months. We're also going to give a better interop. That's a delivery to your clinical systems. System 1, EMIS via Docman 10 or EMIS Direct. And again, we're working on that at the moment. And again, that's imminent in terms of launch. First phase of that may even be 1st of July. So lots happening. It doesn't matter on your clinical system. You download it to your PC. Either your CCG, your IT support, or obviously yourselves will have the ability to do that. And then you'll be using the toolbar. And we'll have things as we upgrade and enhance that with your previous day's analytics, how many eConsults you did yesterday, whatever it may be, and latest news like new templates for medication review and so on. That's it. I think we've covered lots of things.
Great.
It's been a really, really exciting session. We actually maxed out at 207. So
Wow.
I've already got a request for I've already got that request for another session, so I'm going to book you guys in very soon, and we'll record this and we'll make sure it's available and let you know. So lots of questions, we'll capture those, or we'll somehow get them back to you, whether we put it on our website and give you a link. But I hope you found the session beneficial. I'm getting lots of positive feedback, so that's brilliant. Any questions at all? My email address. I'll just put on the screen, drop me an email, and if you want me to link you to Ross and Gerb, I will do that as well. I'm getting lots of thank yous, but I hope you enjoyed it. It was the first one, and I personally think it went very well. Thank you all for joining.
Yeah, thank you all very much.
Guys.
And good luck.
Thank you for all the interaction. It's been absolutely amazing to see you on the chat screen.
Brilliant.
Fabulous. Thank you all so much. Lovely to see you.
Bye-bye.
Bye-bye.
Bye. Bye.
Gerb and I still here. If you've got any more questions, we'll happy to take them for a minute or so as you drop out. But thank you again, everyone.
Yeah, absolutely. In for a penny, eh?
Lots of thank yous, and go eConsult as well. Good.
Nice. Ah, Rosie's there. Hello, Rosie.
Yes, nurses, we're going to run a session in 2 weeks' time. We'll share the invite pretty much from tomorrow morning, all about long-term conditions, how they can work with contraception, annual reviews, long-term conditions, and much more. And again, GPs, pharmacists, you're all welcome to join as well, but we'll share that with you pretty much from tomorrow, 24th of June, same time, same channel, just different voices.
All right, I'm going to head off then. So, of course, if there's anything else, obviously, Mike, you can let me know. Fabulous. Thank you. Take care.
Thank
Bye,
you
everyone.
Bye-bye. Yes, it's a question come through about healthcare professionals. Yes, you have an admin person or looking at your eConsults and working out who's the best person in your team. So certainly we can help you with that, help you talk about that. I call it a quarterback role. It's somebody that's helping to use your healthcare professionals, your multidisciplinary team. So again, drop me an email. It's on the chat channel, and we'll go back from there. Yes, again, drop me an email, Anne-Marie. We'll happily help you set up and talk to you about your model, working out the best way to make it work and getting the best out of eConsult, best value, and making sure your clinicians are seeing it and getting the best working day they possibly can. Okay, well, that's final questions, I think. I'll leave you to your day. Thank you for joining. It's been brilliant. We will do it again. We will share the information, obviously, about the nurse event, and ultimately, we'll run the session again. And if you want to join again, you certainly can. Thank you.